Dalmas Lokok from Turkana, from a sub-county called Loima. Maybe to say something about the picture. That's a stage view from one of the units who is filling up the PMR. And she's coming from a village like 30 kilometers from the link facility. So my colleague from Samburu was talking about the vastness. Turkana is one of the largest county in Kenya. A problem statement, the engagement of community health CHBs to support the delivery of health programs in an established approach that has improved access to primary health care and health outcomes, and other sub-areas that is particularly where are health inequalities due to scarcity of the trained human resources. We are just like Samburu. The area is vast, the distance, and even the health workforce is very minimal. So Turkana has been implementing SISTOC in 3 sub-counties. We have Kibish, that is near Ethiopia. We have South, bordering West Pokot, and then we have Loima, bordering Uganda. So we have 7 sub-counties, but where we are implementing is only 3 sub-counties. So we can see a gap there. Challenges still existed, and CHVs had difficulties in reporting, among a number of obstacles in executing their work, including challenges in managing health commodities, low literacy level, inadequate reporting tools, that's what we are facing even right now, low capability to complete reports because of the literacy level, an existence of avenue for submitting community reports affecting product availability, inadequate access to health services, especially in arid and semi-arid areas. That's where we are as Turkana County. We are in arid and semi-arid areas, whereby we don't have even public transport, where CHV walks for like 40 kilometers to go to the link health facilities. That's where we are. And in Loima, we have 34 community health units linked to 34 facilities. But here we are piloting 17 link facilities. That is 17 community health units. And how we implemented stepwise. Step 1, the PEMR worked with the SISTOC on smartphone. That's between August to December 2020. Step 2, stock PEMR. Then that's when we merged PEMR and the SISTOC. We did a usability testing with the CHVs from 3 CUs, that is Nasigar, Namayana, and Lorengipi. That is within Loima. And and we used the smartphones during that time of the usability testing. Step 3, when we were designing the PEMR, we had the Kias, that's a smartphone, like a Wizi kind of phone that we used to redesign the PEMR. That was between March and May. Step 4, the feature phones, usability testing, with the 30 CHVs and 3 CUs, the CUs that I've said. We were using the feature phones to pilot the PEMR. And then we did the rollout. We give all the CHVs, the 200 CHVs in Loima, the feature phones for them to use in terms of reporting through the SISTOC. And the 17 CUs, with the support from the 17 CHAS, that was July and August. Monitoring, that is what is like ongoing now. We are doing monitoring, measuring, and performance of the results. It is ongoing now because August and September, we can see it from the data. How it works, briefly, a CHV should log in to a browser, and then the CHV has credentials, and then it will take a photo of that paper. That is hybrid paper that is digitalized, so that it will capture the report. And the report will be captured, and then it will be uploaded to the cloud. And the data comes in terms of the figures. So you can see it is even linked to the KSIS of our systems. The overview of that is hybrid paper into the digital implementation success. What happened to the CHAS, that is the community health assistance, has more control over data quality through community health assistant dashboard. We have that dashboard. It's able to manage the The community health volunteers for the CU, by editing details, they can add and they can disable the CHVs. Is able to delegate report on behalf of illiterate CHV or those without a phone. Is able to validate data sent by CHV, or if incorrect, send it back to the CHV to make corrections. The chair is able to monitor CHV's reporting numbers and remind CHVs to submit reports. The chair is able to view stock status for each CHV, which guides in supply of commodities. For a CHV, the CHVs are able to identify which commodity they are dispensing through pictures or icons on the inventory of the inventory cards and stock cards app. The CHVs are able to manage the commodities issued to them by reporting quantity of commodities dispensed, received, and stock at hand or at the end of the month. The results. So we've trained 200 CHVs who are given the feature phones in 17 units, as I said. 200 CHVs have smartphones, a courtesy of inSupply Health and Telecom. That is a plus to us. CHVs are able to document the number of commodities they receive, which, when compared to monthly consumption, guides the facility in charges in forecasting and quantification of commodities required at the community level. CHVs manage a number of commodities, started with 17 which are trained. In Loima, we only have 17 units that are managing the commodities. Monthly data discussions, we have a WhatsApp where we have a platform that we do. Yeah, we have a platform for WhatsApp where we do interact with the partners inSupply Health, other partners like Save the Children, in terms of reporting on the C-stock. Stockouts are detected by the system. For instances where CHV receives 0 commodities, yet they order to be resupplied with the particular commodities. It's possible to know the consumption quantity of each commodity issued to CHV monthly. Coordination with partners, as I said, mostly Save and inSupply Health, that the ones who are supporting us to monitor this activity. Other experience sharing, what has worked well, CHVs who are already trained on C-stock before made it easy to roll out the hybrid paper in digital. So they can easily do that. Sorry. The community assistants were knowledgeable on the reporting on C-stock plus testing. That is what's happening in Asger, Namayana, and Lorengipi, as I said, for the rollout of the paper EMR. The technical team, who is Kenny, George, are quick to support when challenge arises, especially using the WhatsApp. So we appreciate you guys. As HV have phones, courtesy of Supply Health, with Telecom also. So we're really proud of you guys, and we need your support to continue. Challenges, we have network challenges. It's difficult for some places where we have challenges with network to do the reporting. So it's a big challenge in our county. We had 4 CHVs who lost their phones, but with the support of the community health assistant, they still report. Lesson learned, the reporting using phones in Turkana has enabled team to have data for decision making through the impact teams. And in Turkana, the Mulkambuis that we are using, it is very key for reporting. Visibility of CHV, data is clear. Now it's clear which unit and which CHV have which commodities. So we are able to monitor commodities. Thank you so much.